Welcome to those of you who are joining us tonight. We're happy to have you. Heather, I'm going to let you have it.
Sure. If you could please go to the bottom of your screen and click on the globe at the bottom, you need to select either English or Spanish. Esta sesión está disponible en español. Haga clic en el globo terráqueo en la parte inferior de la pantalla y seleccione español. Gracias.
Thank you, Heather, and welcome to this webinar this evening. I'm sure we will have more people join as we get started. Tonight, we are focusing on women and the difficulties that they face with their bleeding disorders in the ways of diagnosis and care. And we are very fortunate tonight to be partnering with our friends at the Foundation for Women and Girls with Blood Disorders. Tonight, we have the lovely Dr. Roshni Kulkarni and Carrie Funkhauser. If you're not familiar with HFA, we were founded in 1994. We work to assist, educate, and advocate for members of the bleeding disorders community. These are our education sponsors for 2022, and we thank them. In May, HFA is raising awareness about health barriers and challenges in the bleeding disorders community that exists for women. We continue to hear cases of women struggling with healthcare and diagnosis. We hope to provide education, advocative measures, and resources to strengthen support for patients and caregivers. Tonight, we will be joined by Dr. Roshni Kulkarni, who is a professor emerita of pediatrics at the Human Development and director emerita of the Michigan State University Center for Bleeding and Clotting Disorders, and was a former director of pediatric adolescent hematology and oncology. She was the director and distinguished hematology consultant, Division of Blood Disorders at the Center for Disease Control and Prevention in Atlanta, Georgia. She is widely published and is founding member for the Foundation of Women and Girls with Blood Disorders, as well as holds memberships on numerous national, international, and federal committees. In 2016, she was honored as one of the women leaders in hematology in the American Journal of Hematology. She has received numerous awards that include Eternal Spirit from the Coalition for Hemophilia B, Fairy Godmother to the Women with Hemophilia by the Hemophilia Foundation of Michigan, NHF's Physician of the Year, and MSU's Distinguished Faculty Award and Distinguished Service Award from the Federal Drug Administration and the CDC. Wow, we are lucky to have you tonight with us, Dr. Kulkarni.
Thank you.
We also have Carrie Funkhauser, who is the Executive Director of the Foundation of Women and Girls with Blood Disorders. Carrie works closely with the board to set the overall strategy in the foundation and oversees all aspects of the day-to-day management, including partnership development, education, and communications of the foundation. Carrie has extensive experience in the nonprofit sector, including serving as the director of a coordinated school health program developed for the national nonprofit focused on the prevention of cancer and cardiovascular disease. We are so thrilled tonight to share the spotlight with our friends at the foundation, and we are excited to hear from Dr. Kulkarni. Throughout the presentation, if you will please put your questions into the Q&A box, and we will get to them near the end of this presentation. We are set for 90 minutes, so please enjoy, and we thank you for joining us tonight. Dr. Kulkarni, you may share your screen, and we are so excited to hear from you. Thank you so much.
Thank you so much. I really want to thank the Hemophilia Federation of America for inviting me to address this important issue on barriers and challenges for women and girls with bleeding disorder. I think this is an issue we all face, and I'm just trying to see whether I can, address some of the barriers and health disparities and health inequities and see what we can do to overcome them. So let me stop my video so you'll concentrate on the slide. So what I will do is do a brief overview of women and girls with bleeding disorder, including the types and how they present, and what types of barriers do these women encounter, or even girls encounter, and how does it affect them, and identify some health disparities and strategies to address these barriers and achieve health equity, and also address social determinants of health. So, how do barriers to health care and health disparities affect women and girls with bleeding disorder? I just want to tell you that when I say women and girls, if I include the LGBTQ plus and others who have a potential to menstruate or bear children. So this is inclusive of everybody. I just want to make sure all of you understand that. So we know that women and girls are disproportionately affected due to bleeding challenges of menstruation, which occurs monthly, and childbirth. Actually, in many girls, menarche or the beginning of menstruation is what we call the first hemostatic challenge. Overall, 1 in 5 women and girls experience heavy menstrual bleeding. It used to be called menorrhagia, but now the correct term is heavy menstrual bleeding. 1 in 4, or almost 20 to 25%, have an underlying bleeding disorder. So, hey, we are missing these people. They really need to be diagnosed. And in those who have an underlying bleeding disorder, 90% have heavy menstrual bleeding. Now, this just doesn't stop with menarche. During pregnancy and delivery, women and girls with inherited bleeding disorder have 10 times higher mortality. This is really a sad thing, and I am personally affected by it since I lost my aunt, my father's sister, to postpartum hemorrhage. So besides all these things, we often see other conditions such as miscarriages, painful ovarian cysts, and very painful endometriosis. And women are more likely to undergo hysterectomy when they have an inherited bleeding disorder. Now, these disorders are lifelong. And this is a slide modified from Dr. Andra James. As you can see, it starts out with, these are very unique issues for women and girls. Starts out with heavy menstrual bleeding and early exposure to hormonal therapy. Then goes on, there's a risk to the pregnant woman and her unborn baby. And in many cases, pregnancy causes an increased risk, not only during the entire pregnancy, but also after the birth of the child. And then many of these women have to undergo regional anesthesia. And of course, the child itself is at risk for having the inherited bleeding disorder. And we already talked about postpartum bleeding. And you would think it would stop with that, but oh no, in menopause, perimenopausal, and postmenopausal women also experience surgical bleeding because it's that time when they have perimenopausal bleeding and bleeding because of all kinds of surgeries, biopsies, etc. So what are the types of inherited bleeding disorder? I'm not going to go into each one of this, but you can see von Willebrand's disease is the most common. And, women and girls with hemophilia, as well as carriers of hemophilia, platelet function disorder, rare bleeding disorder. And then there are these other disorders, hereditary hemorrhagic telangiectasia, which are like little blood spots all over. And these patients can have severe nosebleeds. And what is, I think we are realizing more and more common is hypermobility or Ehlers-Danlos syndrome. These are patients who have like flexible joints and they have really loose connective tissue and they can bleed easily. Why do we need to know about these women and girls with bleeding disorder? As you can see, the top graph shows the number of women who are seen in the hemophilia treatment center has been increasing over the years. And this was a recent publication from the CDC. Even across the world, the number of women, and this is particular reference to von Willebrand's disease, but this is with regard to any inherited bleeding disorder, the number of women, as outlined in red, have increased like 79%. So it's all the more reason we need to know about these women and girls. We need to diagnose them early, treat them early and appropriately. What are the bleeding manifestations that these women and girls experience? You can see most of them, almost in some cases, 100% have heavy menstrual bleeding. Then they have nosebleeds, bleeding after dental surgery, bruises, very easy bruises. Sometimes I see patients in the clinic and they have no clue where they got these bruises from. And they can bleed pretty severely from minor cuts and abrasions. And we always ask this question in the clinic, do you bleed when you brush your teeth? And joint bleed is something which is being recognized more and more. A lot of people miss that. When women complain of joint bleeds or joint pain, people think, oh, that's just a woman complaining of pain in the joint. But believe me, there are women who really have joint bleeds. And gastrointestinal bleeding can happen. And of course, pregnancy and postpartum bleeding. So you can see this is throughout the woman's lifespan, in childhood with nosebleeds, bleeding from minor wounds, to adolescence where they have heavy menstrual bleeding and bleeding during ovulation. This is mid-cycle bleeding. And again, bleeding with surgery. And late adulthood, you have this bleeding with pregnancy. And I just want to outline that joint bleeding, can occur in these women. And in late adulthood, you can have bleeding in the GI tract and, post-surgical bleeding. So before we go further, I think I want you to know what is normal and what is heavy menstrual bleeding. Well, a normal menstrual cycle begins between 11 to 14 years of age, sometimes as young as 10. And the duration of the cycle is anywhere from 21 days. It's called menses because it's monthly, but it can go as long as 45 days. And the periods last for about less than 7 days or about 7 days. And those who use pads and tampons usually use 3 to 6 pads or tampons per day. And the blood loss, people have measured how much amount of blood do you lose. It's about 25 to 80 ml, which is like, a couple of teaspoonfuls of blood, about, I think 16 for all the duration of the menstruation. Heavy menstrual bleeding, on the other hand, lasts for a longer time. I have seen women and girls who have bled for like 14 days in a month. I mean, it's life-changing. Their whole life is all about bleeding. It's really sad. And they change pads and tampons every hour. And many of them leak and soak through clothes. They're ridiculed at school. And it's really, they feel ashamed of it, although there's really nothing to be ashamed of. Or sometimes wear more than one pad at a time to control menstrual flow. Just imagine those people in the world who don't have access to menstrual pads and tampons. They use rags and paper and leaves and things like that. And another indication is that Plas clots, or these are lumps of blood the size of a quarter or more. And there are other symptoms that these women and girls experience that it keeps them from doing things that you would normally do, like going to work, going to school, etc. Constant pain in the lower part of the stomach, tired, lack of energy, or anemia. So what is the prevalence of heavy menstrual bleeding in women with bleeding disorder or girls with bleeding disorder? Almost 100%. Sometimes in von Willebrand's disease, can range depending on how severity of von Willebrand's disease is. And in platelet disorders also, it is pretty high. You can see in all of them, it's pretty high. I mean, one has to know this. We hope to educate all the physicians and the non-physicians, family practitioners, nurses, etc., to recognize this. So 1 in 5 women have with the heavy menstrual bleeding, have an underlying bleeding disorder. And we did a CDC study that showed that there may be racial differences in the prevalence of platelet disorder. So in that study, more Black people had platelet disorders compared to white women. What about miscarriage, antepartum, and postpartum? Partum is delivery. So miscarriage is pregnancy loss before 20 weeks. Antepartum is vaginal bleeding from 20 weeks till delivery, and that's seen in about 2 to 5% of pregnancy. Postpartum is more than 2 cups of blood loss vaginal or 4 cups post C-section. And we usually classify them as primary postpartum hemorrhage that occurs within 24 hours after delivery, or it can be very severe, even requiring transfusion, and a secondary postpartum hemorrhage, 24 hours to up to 12 weeks following delivery. Now, what's the importance of that? Primary postpartum hemorrhage we can recognize because the woman might still be in a healthcare facility. But secondary postpartum hemorrhage is often missed because the woman goes home and her family says, "Oh, that's pretty normal for you to bleed." I usually tell my residents and fellows and everybody that when you are seeing a baby, I practice pediatrics, when you're seeing the baby, please turn to the mother and ask her, "Are you still bleeding? How many days have you bled?" Just simple questions might give you a clue whether the woman is having more than usual bleeding. And look at this. This is fascinating. So primary postpartum hemorrhage, which occurs within 24 hours, normally is seen in about 4 to 5%. Look at this. In all these bleeding disorders, 16 to 22%. That is huge. Secondary postpartum hemorrhage, where the woman bleeds and bleeds and bleeds and bleeds after delivery, 11 to 28%. And the number of women who undergo hysterectomy, 26%. And in other rare bleeding disorders, it's anywhere from 25 to 76%. We think that hysterectomy is an end to your problem, but remember, a woman is not a uterus, for heaven's sake. Just getting rid of the uterus doesn't get rid of your bleeding disorder. You can bleed from other surgeries and all that. And hysterectomy has its own problems. If you talk to women who have undergone hysterectomy, they'll tell you sometimes they have prolapse and things like that. In some women, it works, but in some women, it can lead to other problems. And this is just to show you what happens in a village, it's usually surrounded by women bleeding to death. And so what do we do to evaluate, when we are suspecting a bleeding disorder? So I say history, history, and history. And so all of you who are patients who need to know your personal history, whether you've had heavy bleeding since you started having periods, bleeding during and after delivery, a history of iron deficiency, anemia, and whatever medications you were taking, and a family history of bleeding disorder. We then do what is called screening tools. This just gives us an idea of whether you have a bleeding disorder or not. And there are 3 of them, and I'll go over this in a little bit. And examination, besides physical examination, we also do laboratory assessment. We just don't draw blood. Sometimes it's really difficult to diagnose. And sometimes we do what we call first tier testing and second tier. And of course, genotyping, unfortunately, is not covered by most insurance companies. My Life, Our Future, venture by ATHN, the American Thrombosis Hemostasis Network, and the University of Washington in Seattle did this, and Biogen, a pharma company, gave free genotyping for all hemophilia patients and their carriers. So this is what is called the pictorial blood assessment chart, or PBAC, to quantify blood loss. And you can see, you kind of measure, you can look at the pad and the tampon. So this is like, if you had 2 pads like this, you had 2 points. And if you have a pad like this soaked with blood, you get 20 points. So you can calculate it. It's a very rough method of calculation. And, when it was first published, the Dr. Hegum really actually looked at all the pads, collected them, measured the blood, that was there on the pads. So there is a total score. And if it is more than 100 points, like this is 265, so it's definitely more than 100 points, it indicates heavy menstrual bleeding or 80 ml of blood loss. This is a menstrual app, which is a free app by the Hemophilia Federation of America that you can download and record your own, period, how your experience was with your periods. And it has a chart where you can chart out where you can feel pain, etc. Now, there are a lot of women who use, or girls who use, menstrual cup. And these are called, different kinds of cups. And very interesting one is a smart cup or a loon cup. It has a chip in it which sends a message to your iPhone or your watch saying that my cup runneth over. Time to empty your cup. Now, it's very interesting. A lot of people, there was an article in BBC from London where they had donated these cups to these girls who were attending schools, because a lot of countries don't have facilities to get rid of your pads and tampons or rags or whatever you have. But they can easily empty this cup and reinsert, and cup can last for a long time. So be aware that there is something called menstrual cup, which is used all over the world. Now, there is this other screening tool, which tells me as a physician whether you have heavy menstrual bleeding. And it just have to be one of the 4 criteria. That is bleeding for more than 7 days, flooding or gushing of blood that limits activities, passing clots that are bigger than a quarter, changing pads, or a diagnosis of anemia or have received iron therapy or a family history, and bleeding following dental surgery or other surgery or childbirth. This particular tool is available on the CDC website, both in English as well as in Spanish. So please, if you are a healthcare provider, do use it in your clinic. Then there is the International Society on Thrombosis Hemostasis Bleeding Assessment Tool. And again, it's also a screening tool. And what it does is that it looks for symptoms of spontaneous bleeding, as well as bleeding following hemostatic challenges. So spontaneous bleeding is like bruising, intracranial bleeding. It can be mild to very severe bleeding, heavy menstrual bleeding, bleeding in the urine and all. And hemostatic challenges are like surgeries or postpartum bleeding or tooth extraction. So there's a bleeding score which is calculated. So there's a way to calculate it. And you can see children have, 0 to 2 bleeding score, and males have 0 to 3 and women 0 to 5. So when you evaluate a suspected bleeding disorder, I already mentioned all this. Then we do all these testing. So it kind of gives you a headache. So you start out with a simple blood count. Are you anemic? Is your sometimes low thyroid hormone levels can give you heavy periods. And we check your iron levels because that's very important, because iron is something when you lose it out of your body, it's gone forever. And we do like screening tests for all these clotting factor levels, platelet aggregation, and of course, genotyping whenever possible. So how do we manage these women and girls with bleeding, who have bleeding? So this is a wonderful chart by Dr. Rezan Kader from UK and Andy James of our own, who's the president of the Foundation for Women and Girls with Blood Disorder. So if they want to preserve fertility, they can use either hemostatic measures, so drugs like tranexamic acid, DDA-VP, which can be given in the nose or under the skin, and clotting factor replacement for those who have clotting factor deficiencies. Or you can do hormonal measures. And we usually consult an OBGYN before we start hormonal measure. And in women who do not want pregnancy and all measures have failed, one could consider endometrial ablation and hysterectomy. And during pregnancy, we have to check factor levels, if they have a factor deficiency, and give factor concentrates or tranexamic acid. And the idea is to prevent postpartum bleeding. So you can see that menstruation affects all aspects of a girl's life or even a woman's life, such as education, economics, participation in sports. I should tell you a story about economics. These women who work in cane fields, this was a story reported by one of the news media, that these women in Bombay, India, kind of underwent hysterectomy. They were told they will have cancer if they don't go hysterectomy. And they wanted to undergo hysterectomy because periods kind of interfered with their earning. They were given hourly wages. So every time they missed due to a pregnancy or heavy periods, they lost money. And a lot of them opted for hysterectomy. And clearly, dignity is a huge issue. These girls endure teasing and shaming. And in Uganda, they found that many of these girls, they don't stand in the class to answer because they can soil their clothes. And they have a concern about odor because they sometimes use rags. And so menstruation causes a lot of issues. It's full of taboos and myths and restrictions, domestic or religious. Like, for example, menstrual isolation. My mom practiced that in India. I wasn't allowed to touch her when she had a period. They're kept in a room. And, stigma, period poverty, etc. So the consequences of bleeding are many. It's just not the bleeding and the uterus, but you can see it sometimes leads to hospitalization, iron deficiency, anemia, limitations in daily activity. The woman in many countries, including this, is really the caregiver of the family. So when she is unable to work, or when I say work, whether it's working in the house, or outside the house, when you are not feeling good and you're anemic, you just really can't do those activities. And of course, wages are lost, time is lost from work, school because of absenteeism. And it really has adverse psychosocial effects, affects quality of life. And a lot of them undergo unnecessary procedure. And then clearly there are consequences on the baby. And so why do we need to know this? Because we know that barriers to care, early diagnosis, proper diagnosis leads to health disparities. And that leads to health inequities, which really, really affect women. And all these are influenced by social determinants of health. So one of the biggest barriers is the capacity to seek care and transportation to care. And even once they get there, it is hard for a lot of these women to receive appropriate skilled care. What about barriers to diagnosis? So it's interesting. A lot of women are not aware that they have a bleeding disorder because the symptoms are dismissed by their family, because their mothers have gone through this, their grandmothers have gone through this. They'll say, oh yeah, heavy menstrual bleeding is a normal thing in our family. Everybody does that. But interestingly, even the healthcare providers may not be aware. And that is what we are trying to do at the foundation, is to educate the healthcare provider. As I said, access to care, lack of proper testing, and then all these biases, isolation, stigma, racial, cultural biases, et cetera, and use of outdated, confusing terminologies is a big issue. So I have listed them here. So there are financial, social situations, period poverty, where they can't afford all these products. And then clearly, laboratory diagnoses include lack of testing, when to test, how to test, where to test. I mean, it's especially, we do clinics in the Upper Peninsula of Michigan where, trying to get blood to test, especially platelet function tests are really a challenge in the remote areas. And then you have the big issue of digital inequities. That means lack of access to telemedicine, telehealth, that can allow, virtual examination of these patients. So delayed diagnosis so I'm going to kind of go over a little bit of the barriers and then talk about how to maybe try to overcome some of them. So delayed diagnosis. So this was a very known CDC study in 2002, showed that these were women with von Willebrand's disease, and it took 16 years from heavy menstrual bleeding to a diagnosis of bleeding disorder. 16 years, man, that's a long time. So they did a survey of OBGYN saying, okay, when you see a woman with a bleeding disorder or heavy menstrual bleeding, what do you think? Well, less than 1% and about 42 thought that bleeding disorder is a part of heavy menstrual bleeding, and 42% reported never having even seen heavy menstrual bleeding in a bleeding disorder. So there was total lack of awareness of the healthcare provider. In 2012, after we worked hard with the ACOG, the American College of Obstetric Gynecology, the National Hemophilia Foundation, the Federation of Hemophilia Federation of America, and all that, they repeated the survey, and then you can see it improved. 39% said yes, they would consider heavy menstrual bleeding in patients of reproductive ages, and 77% of adolescents. So much so, the American College of Obstetric Gynecology issued a statement saying that OBGYNs, if they see a girl with heavy menstrual bleeding, they should consider a bleeding disorder. And so lack of awareness by healthcare provider leads to lack of referral to hematologists, lack of proper testing, normalization, stigmatization, and dismissal of symptoms. So this is dismissal of symptoms. And so there is a need for self-awareness and advocacy. And really, you have to have access to treatment plan. So this was a study from Canada, which showed, why do you get diagnosed? Why does it take such a long time to get a diagnosis? Well, if you have mild symptoms, you're more than likely to have a delayed diagnosis. Rural Canada, minority, you can see that all those contribute to diagnostic delay. And the reason for referral is often a symptom of excessive bleeding, in some cases of family history. What about confusing terminologies? So, carrier barrier, I call it carrier confusion. This was written in HemoWare. So a hemophilia carrier is a genetic designation and not a clinical diagnosis. And many healthcare providers, even to this day, do not believe that carriers bleed. And we know, and I've personally known of so-called carriers who take their sons or brothers' factor concentrate for bleeding episode. Why do we need to designate them correctly as hemophilia? Because it allows insurance coverage and access to comprehensive care. This is a wonderful manga book. It's available on the Foundation for Women and Girls website, written by Dr. Nishida from Japan, who was trying to raise awareness about carriers. So if you get a chance, it's a pretty nice, well-written book. So what is this affected? What is a carrier? So a carrier is supposed to have one affected X chromosome. So all of us women have two X chromosomes, but we don't really need two X chromosomes in our body. So one of the X chromosome becomes what we call inactivated or bar body. So all you need in your body to function in every little cell of your body is one X chromosome. It can be the red, which is abnormal, or it can be the blue one, which is the normal one. So in every organ, there are some cells which may have this abnormal chromosome and some cells which have a normal. If it just happens that all the bar bodies are normal, then you have hemophilia, like this person. Or if you have all the normal, chromosomes, all the abnormal chromosomes, or the red ones, which are inactivated, then you get a person who looks perfectly normal, has normal, no bleeding, normal factor levels. But the most important thing to remember is they can transmit it to their offspring. All right. So this process of this bar body and all that is called lionization, and it's random. So you never know which cell has the good X chromosome or the affected X chromosome. So carriers can be symptomatic or asymptomatic. That means they can bleed or they may not have to bleed. So for every 100 males, there are 277 possible carriers. And so there are 20,000 males in hemophilia in the US. Therefore, there could be 55,000 carriers. Hey guys, we are missing them. We don't know where they are. We need to find them. So 1/3 of women and girls carrying the hemophilia genes have the symptoms. So what we have done, Dr. Karen Van Galen, Robert Sidonio, and us, Peter Quides and all, we decided we need to change the nomenclature. So any woman whose factor 8 or 9 level is less than 40% is termed hemophilia. And she can be mild hemophilia or moderate, just like the men. Less than 1% is severe hemophilia, 1 to 5% is moderate hemophilia, and greater than 5% is mild hemophilia. Those with levels greater than 40% are considered symptomatic carrier if they bleed, or asymptomatic carrier if they don't bleed. Now, the physicians are trying to see if we can increase this level up to 50%. So we'll see whether that will be accepted. So there are a lot of issues with laboratory diagnosis. These levels, whether it's in von Willebrand's disease, hemophilia, factor 7, etc., fluctuate. They change. And pregnancy causes some levels, such as factor 8, factor 7, 10, etc., to go up, and levels like factor 13, protein S, to go down. So first of all, there's a lack of availability. And the question often comes, when to test, where to test? Should we do a central lab? A lot of local labs don't do that. It's really not cost effective for them to set up, testing. And factor levels, as I said, change with age. For example, factor 9 is low in newborns. It's a vitamin K dependent factor. So it usually reaches normal level by about 6 months to age or older. So we have to recheck them. And then these bleeding assessment tools I talked about are always not reliable. What if you don't use pads and tampons? How can you measure some of those things? And this is to show you in hemophilia carriers are in red and normals are in yellow, and they overlap. So, just getting a blood sample and getting a diagnosis is not that easy. And that's why, please forgive us doctors when we say we need to redraw your sample, we need to retest you. Well, that's because sometimes it's a challenge. It takes time to establish diagnosis. So there are a lot of use in women, women's reproductive health. They're undermanaged, inconsistently managed, undertreated, underrepresented, understudied, underfunded. I think they all belong to the University of U, which is everything is under. Studies often enroll patients only with severe disease, and a lot of these women have varying levels. Very interestingly, we talk in all clinical studies of annualized bleeding rate. For some reason, they don't think of heavy menstrual bleeding, which is monthly, and pregnancy-related bleeding as a part of annualized bleeding rate. Women of color, LGBTQ, are rarely included in clinical trial. And there is a general mistrust of pharma and other non-pharma studies in certain cultural groups. Furthermore, we don't know how these drugs act in a woman. Are they the same as in a man? So when you give a drug, you measure how high the levels go, how long they last. Those are okay for men, but very, very few studies have concentrated on pharmacokinetics and pharmacodynamics. That means how the drug behaves. Pain, depression, anxiety, quality of life are really not well defined, and we don't really have many things to treat them with. Gene therapy, oh my goodness, it's just a dream for women and girls with bleeding disorder, but I think it'll come one day, I hope. So there are gender barriers, age barriers, financial barriers, and ableism barriers. So Angela Wayne and Paula James did this wonderful paper on sexism, how menstruation is stigmatized, and patients and providers are not aware of what constitutes a normal period, and resources are dedicated to men and diseases associated with men. I'm not saying don't do that, but also do it in women. What about ageism? Ageism is fluctuating levels of clotting factor, and especially with von Willebrand's disease, levels go up. Does it mean they stop bleeding? Not necessarily, but they can go up. Ableism is, what about, there's an ignorance of age-related comorbidities. We talked about joint disease. How many of them have disabilities? Joint, osteoporosis, cancer, etc. And there's definitely racial and ethnic disparities. So I call them the ism disease, sexism, racism, ageism, ableism, and culturism. So we need to get rid of all of them. What about stigmatization? Well, in Nepal, they have this menstrual huts called chaupadi, where menstruating women are isolated. And this is not only in Nepal, but it's banned by the Supreme Court, but it's still followed. In other countries also, this occurs. These women succumb to cold, hunger, dehydration. They have poor access, and some of them die. There's domestic violence and rape. And if you're sitting in this little hut and bleeding away and nobody to know what the heck you're doing, you can die. And there have been deaths reported, from snake bite, from bleeding, from smoke inhalation. They have to keep these huts warm, so they light fire. And sometimes that smoke inhalation can do that. What about period poverty and menstrual equity? Well, there is inadequate access to menstrual hygiene tool. Period poverty is global. And you can see here in Australia, 27% students can't access period products. In India, 20% drop out of school, and 88% are use sawdust, rag, cottons, newspaper, etc., etc. Many countries tax menstrual product, making it unaffordable. Sadly, COVID-19 pandemic exacerbated this period poverty because there was a lack of availability of product, increased cost, isolation and quarantine. And to add to that, there was wage loss, etc., etc. So I think we should be aware of period poverty and what to do about it. And we are doing things about it. So this was interesting, just the cost of menstrual product. You can see here, this is, quite expensive for a lot of families. I usually ask my parents of my patients, young adolescent girls, how much are you spending? You can see if you're bleeding, if you're menstruating like half your month, imagine how much you're going to spend. So interestingly, if your menstrual cup, it costs about $20 to $40 and they can last for 10 years. So this is maybe a good alternative. Some people like it, others don't. And then you have this menstrual period panties. And, and of course, you have to take into consideration pain medication, loss of, cost of laundry, etc. And so women and girls with bleeding disorder, they really, I think, have to pay a lot more for their products than those without it. So how do you overcome some of these barriers and disparities? Well, we talked about period poverty, and recently in Michigan, the governor decreed that, if you can get toilet paper for free, for God's sake, why can't you get pads and tampons for women and girls, So I think we should talk about period poverty. We should destigmatize. We should eliminate the taxes. So I think Scotland was one of the first countries to do it. Many places in the United States are doing it. I found out in the 85% of the US colleges and universities, including mine, provide free condoms. Holy cow. If you can provide free condoms, why can't you provide pads and tampons? So we must advocate for menstrual equity, not only in our country, but in developing countries among persons of color, migrants. So I am sure HFA is taking this seriously. So what about overcoming barriers of access to care? So remember, I talked about digital inequity. You can overcome that by providing physical outreach as well as virtual outreach. And this is what we do. We live here, about 500 miles is Portage, and Dr. Colleen Ballard Hicks works there. and Marquette General is 400 miles. So we go there and provide care for patients with bleeding disorders. And, sometimes you have an outreach clinic. We have outreach clinic just like some of the other centers with the Amish population. So I was just there last week meeting with the elder at the Amish population to see whether we could have mobile dental clinics that can provide local care for these people. And one of the ways we have addressed barriers is and Carrie is going to talk about this a little bit more, is the Women and Girls with Bleeding Disorder Learning Action Network Clinics of Excellence. So these are collaborative clinics. This is our collaboration. These are adult hematologists and myself and the nurses and OBGYN. We have a new OBGYN now, and Diane McDonald is still working with us. Thank you very much, Diane. And it's a collaborative clinic, and it is so much fun, really. I mean, I learn a lot from the OBGYN, and I think they have a different aspect, and hopefully they go and teach other OBGYNs what to do. And Kerry will go over all the booming land clinics that have cropped up everywhere in the United States. And the idea is to provide access to specialty care, timely diagnosis, and a forum for collaborative research. And the European folks also have principles they have elicited for care. I'm not going to go into this because they are really paying attention to women and girls with bleeding disorder. So if we reduce health disparities, we can achieve health equity, and we can improve health risk and reduce by addressing social determinants of health. This is a very popular picture where it shows the best way to do this is to get rid of the barrier, which is that little fence. I mean, you can do other things, support them equally and whatnot, but you have to think about ways that you can include and involve everybody. So the big buzzwords nowadays is the social determinants of health, and they're driven. Health disparities are driven by social and economic inequities. And racism and discrimination, of course, plays a huge role. But I have highlighted transportation. Remember, if you can't get to your care, you can't get care. And care should be linguistically, culturally, and appropriate and respectful. And all these economics and education and food and etc. have a major influence on outcomes such as mortality, morbidity, life expectancy, etc., etc. So, in conclusion, how can we achieve health equity? By educating patients, providers, and community, raising awareness of bleeding disorders, improve access to care, and reduce digital inequity through virtual care. And you can do physical outreach, virtual outreach, combination, hybrid outreach, whatever way. The important thing is to reach out to these patients, reduce diagnostic delay, timely and accurate diagnosis, advocate funding for clinical trials to get better treatment, and address racial, gender disparities, cultural competency, which means you have to be aware and be respectful of the culture, reduce stigmatization, period, poverty. So my mantra is, if you see a girl or a woman with a bleeding disorder, please, please, see me, hear me, believe me. And so this is for all the women with bleeding disorders. Hats off to you. Thank you so much. I'm honored to serve you. Thank you.
Thank you so much, Dr. Kulkarni. That was wonderful. The question, the Q&A box is filling up. This is your opportunity to throw those questions into the Q&A. Next up, we have Carrie Funkhauser. And after her, we will move into our Q&A.
Oh, I'm sorry. I have to stop share, right?
Yes, ma'am.
This is too high tech for me.
There you go.
Okay.
Carrie, you should be good to share.
Oh, the increase in diagnosis. Do you want me to say the questions or do I wait till she's done?
Oh, we will do that after Carrie. Thank you. Perfect.
1 second. If I can change this, I apologize.
By the way, my name is spelled Kulkarni. I'm called Dr. Cool Cat by my kids, my patients, I mean.
I love that. We will call you that too. Everyone got that? Dr. Cool Cat.
Janetta, is this, are you able to see them now?
It looks great.
Oh, thank you. And thank you, Dr. Kulkarni. I could listen to you forever. I'm so happy to work with you. And I am also really pleased to be here tonight. Thank you, HFA, for inviting the foundation and allowing us to share a little bit about the work that we do. And before I get into the foundation and its work, I know we are all calling from all over the United States. And so because of that, I thought I would share a little bit with you about where I am from, which is the state of Idaho. And as someone who lives in the state of Idaho, you can never start a presentation without sharing a little bit about it, because people only seem to know us for our potatoes, which if you've never seen them, they are that big. And they always confuse our state with the state of Iowa. So I need to set that record straight. Idaho obviously is out west. It borders several states, including Washington, Oregon, and Utah, Montana, and Wyoming. And I'd like to tell you where I am from, and that is in the mountains at an elevation of about 6,500 feet in a ski area called Haley, or better known as Sun Valley. And in Idaho, there is a lot to see, as you can see from these photos. It's a very big state. In fact, it is so big, it's bigger than all of New England combined, including Maine, Vermont, New Hampshire, Massachusetts, Connecticut, and Rhode Island. The state stretches all the way to the Canadian border and would take you about 10 plus hours to drive there through it from top to bottom in one day. There's lots of mountains and lakes you'd see on the way, farms, as well as open space. In fact, we have about 4.7 million acres of wilderness in the state, which is really nice. But traveling for me and the other 19,000 people that live just in my county is really part of our daily lives, especially if we need to visit a healthcare specialist, such as a pediatrician or a cardiac surgeon, or even a specialized hematologist. For those, I have to travel to Boise, which you can see is that star on the state, and that is 2.5 hours away. But for someone who lives in northern Idaho, that may take quite a bit longer. So some of you may be able to relate to that notion of driving to receive specific and specialized care, and definitely touches on what Dr. Kulkarni was saying in terms of access and availability of care. So the reason I'm sharing this is because it relates to the topic we are speaking about today, and more importantly, to the work that our foundation has been doing since its inception. So tonight, my job is to briefly describe the foundation, explain how we are working to share information, offer education, and turn best practice into everyday practice in order to improve care for women and girls. So the mission of our foundation is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. And as Dr. Kulkarni already shared, we know undiagnosed, untreated blood disorders in women have medical consequences and very unique issues at every life stage. And a delay or failure in diagnosing and treating these blood disorders are really major public health problems. And so in 2010, when Dr. Kulkarni and two of her colleagues got together, they discussed how each of them had been seeing an increase in the number of women who had been waiting for a diagnosis or waiting for a proper diagnosis. And they also recognized at that time that their colleagues really needed more information and training that pertained to the recognition and identification of these unique issues, as well as their management. At the same time that they were meeting, a study was published by one of our former board members and now a medical advisory committee member that really reinforced what they recognized. And the study was performed by Dr. Jennifer Dietrich, and it surveyed 241 OB residency programs regarding the education that they received on heavy menstrual bleeding. And they reported that they received 9 hours of training in medical management of HMB or heavy menstrual bleeding, their intern year, and 11 hours their second, third, and fourth years. 67% reported that training and bleeding in HMB and bleeding disorders was sufficient, and less than 25% reported that they would send tests for specific bleeding disorders. And so they also showed that they were inconsistently asking the appropriate questions regarding bleeding history. And as Dr. Kulkarni said, history is so important. So with this information, it was then that our founding mothers, and we affectionately call them, decided that they needed a foundation whose mission is to focus on the education of key health providers caring for these women and girls, that's where we needed to focus our energy. So the foundation was opened and it launched in 2010. And to reach our mission, we employed several tactics, and we still do to this day. And the main ones are listed here. And you can see that it's not only providing education, but it entails bringing healthcare professionals together to collaborate and really work together on these issues. So very quickly and briefly, our main strategy, obviously, is to promote education of excellence. And we provide education to healthcare professionals by doing educational programs and presentations at major medical meetings. We conduct our own workshops and symposia. We offer live webinars and journal clubs. And everything that we do is for free because, again, we do not want cost to be a barrier to the materials and the information that these healthcare providers need to care for women and girls effectively. And we try to put every presentation and every, like this one, on our website and on YouTube and some other channels so that access is there and they can freely access it at any time or time of day. We also organize web-based and in-person meetings. So we are all about collaboration. So we feel that bringing experts together to do roundtable discussions or have a colloquium that brings them from multiple disciplines to share ideas, brainstorm solutions, and really focus on the common theme of women and girls with blood disorders. So these are just some of the meetings that we've convened with the CDC. We've worked with ASH, we've worked with ACOG. These are just other societies that are stakeholders in the care of women and girls, and we want to work with them to improve that care, especially when it comes to blood disorders. This is something that we also will do, is that we will take the information from these roundtable discussions and we will create a paper. Perhaps we will do an initiative and we will disseminate that information, and maybe we will give a presentation to officials at the state level so that they're aware of perhaps other barriers regarding funding or access to care, insurance related issues. But as long as we're providing the education and the information, we feel that that is really our place in that. So Dr. Kulkarni spoke briefly about our Learning Action Network. And if you're not familiar with this, this is a somewhat newer initiative. It started in 2013. And so I'm just going to spend a few minutes talking about it because I think this is where we've really made some great progress. Through our work, the foundation has been gaining recognition and momentum as a key resource for providing education and guidance to physicians and other providers. So in September of 2013, we received a call from Dr. Christina Haley, who is at OHSU in Portland, Oregon. And the center staff had been seeing an increasing number of young women with heavy menstrual bleeding within their regular HTC. And now they wanted a designated clinic day for young women. And they were told by their colleagues to contact FWGBD because we would be able to help them, since Dr. Andra James started a clinic at Duke University in North Carolina. So it's a member-driven network, the Learning Action Network. And really focuses on the collaboration between the members. We started with 7 members, and it has grown to an impressive network of 250 individual healthcare professionals from across the United States. They're located within 80 healthcare institutions within 34 states. We also have 2 members in Canada and 1 member in the Netherlands. And I can tell you that this group is incredibly enthusiastic about what they do together to improve the lives of women and girls with blood disorders. Some of the work that they do, sorry, I'm trying to.
Carrie, you've muted yourself.
I
There you go.
can't advance my slides all of a sudden, so I apologize. Trying to. There we go. Is that okay?
Yep. Perfect.
Okay, thank you. Sorry, my apologies. It just
No problem.
checked out for a second. So the Learning Action Network, why we decided to start one was because of all of the reasons that Dr. Kulkarni and some others described. There was locally disjointed care for women. The patterns of referral were not consistent. In fact, sometimes they're non-existent. There was varying diagnostic and treatment evaluations. There was a delayed diagnosis, a failure to even consider a diagnosis. There was a reluctancy to work up if the bleeding pattern was anovulatory, and there was a lack of access to a hematologist with expertise in this area. So the Learning Action Network was something that we felt would be a great method to bring healthcare professionals together to focus on some of these issues. The benefits for the physicians to be part of this is that they get exposure to mentors and training. They have ongoing educational opportunities. They have support for some of their research interests regarding women and girls. And then it also mobilizes the talents of several individuals to work together to really make some progress in this area. Some of the accomplishments that our Learning Action Network has achieved, which we're quite proud of, are a few things that I've listed here. One are treatment algorithms that they are working on. So when a woman or a girl presents perhaps in the ED or in the inpatient unit, that there is a consistent way of working the labs and treating this woman and girl in this institution. There's also laboratory tests that they recommend that Roshni went through in her slides. So it's a really nice way to help some centers that perhaps don't have the depth of knowledge or expertise to know what they are to do when a woman or girl presents with heavy menstrual bleeding in the ED, for instance. Another achievement of our Learning Action Network is a textbook, and it's one of the first dedicated resources on blood disorders unique to the adolescent female, and it provides a comprehensive state-of-the-art overview of blood disorders in adolescents and presents new data about bleeding disorders that affect the female adolescent, and really spotlights the multidisciplinary approach, evaluation, and treatment to combat these blood disorders. And this was something that was written by the land members. They decided they needed to do this. They realized their peers did not have enough education. And so they created this textbook, and we're very proud of that. They also, as a requirement of the land, have to focus on collaborative research studies. And so one of the first things that they tackled was looking at the reliability of VWD testing among centers throughout the US. And that was a multi-center. I think there were 15 centers that participated in that. And it was a great achievement and a great piece of work. So we're very proud of the work that they're doing. But one of the biggest achievements that Roshni referred to, Dr. Kulkarni mentioned, was the development of combined hematology, OBGYN, adolescent medicine clinics. And this is something that some will say that they have a menorrhagia clinic or a heavy menstrual bleeding clinic, but that's different from the clinics that our Learning Action Network are establishing. And the key ingredient really is the combined care of the hematologist and the OBGYN or the pediatric adolescent gynecologist. And as you can see right here, these are just some examples of the clinics that have been implemented since 2013. And again, we started with 7 members. We now have over 45 designated clinics throughout the US, and we're actually updating that right now because we think there's some more. And so there's the Spots, Dots, and Clots clinic at OHSU. There's the Flow clinic. There's a Go clinic in Indiana. These are adolescent clinics, but there are also some now more clinics for adult females. It was a challenge for us to get the participation of OBGYNs, but now we're seeing that they are seeing the value in doing this partnership. And so the number of adult female clinics is growing. So we're very, very excited about that progress. All of these clinics follow a model that we have created, and our land members, our board, our medical advisory committee, as well as patients that are on the clinic advisory boards helped us develop. And so these are the 5 different elements. All of the clinics may look a little bit different depending on where they're located, what their patient population is, their access to materials, services. However, they all place the female at the center, and they all take a comprehensive multidisciplinary approach to care. And so we're very proud of this model. I certainly can share more at a later date, but I just want you to know that there is an outline for these clinics. On our website, there is something called the WGBD Clinics and Services Directory on our homepage. We are in the process of updating this, but over the last decade, we obviously have seen an increased awareness among healthcare providers about the need for having specific services for women and girls. And when we started the LAN, we wanted to know how many HTCs had designated services or, in fact, a clinic for women and girls. And so we performed a survey, and we asked every HTC what their level of services were and if they had, in fact, a clinic at that time. And so we created a directory of all of the HTCs that filled out the survey. And so I think there's about 20 that have not still to this date, but we're working on it. And we list them, as you can see here. If you were to search by state, you type in your city, state, and it'll give you a listing of all of the centers that filled the survey, what their levels of services are, if there are any eligibility requirements to be seen at that center, if there's a designated clinic for women and girls, and if so, if it's adolescent, if it's adult, if they see both adolescents and adults, and if there's designated clinic times. And we also were interested in the types of OB-GYN care, again, related to access of care. And so if they had it on site, if a woman then would have to be referred somewhere else, we wanted to know that. So this is there for you. It seems to be very helpful for people that are moving. We have a lot of college students that look at this, and their providers look at this. Women in the military sometimes will take a look at this just to see, well, what services are available where I'm going to be moving to. Again, this is going to be updated, but if you want more information about it, I'm happy to share that with you. And very quickly, just a couple other things you should know. One big barrier to care is a lack of providers giving the care. And so one of the things that we started in 2016 was a research award to help young providers realize that they can make a career and make a difference in women's lives in this career pathway. And so we offer awards. We offer 3 a year. We've so far been able to support 15 recipients of our awards, and we hope to continue to do this forever and ever and ever, or as long as it's needed. But we support career development as well. And then we also offer, and this is something that anyone can access on our website, we have a lot of providers that maybe have a question, don't have an expert in their area, maybe don't know of a colleague they can call, they can reach out to us and ask our experts, such as Dr. Kulkarni, and who will answer their question within 24 to 48 hours. We list some of those common questions and answers on our website. And we've also started to make some videos so that these commonly asked questions, they have immediate access to the answer and don't have to wait that 24 to 48 hours for that answer. And we also do provider and patient materials. We've worked with organizations such as HFA and the Hemophilia of Georgia and some other centers to create materials that help educate providers about certain conditions that patients can use in conjunction with their provider. Their provider can then help, for instance, in managing a pregnancy with a patient. And so we will create those in concert with other organizations. We are a big believer in not mission creeping and want to complement the great work that organizations such as HFA and NHF do. So we like to do those together, but those are also available on our website for anyone to access. You can download them in our resources section. And last, again, partnerships are what our foundation is all about, whether it's from combining hematology and OB-GYN care to working with organizations such as HFA and working with all of you as participants of this webinar. I don't like to read slides, but I think this quote from Dr. Mayo, he was a physician and surgeon and one of the 7 founders of the Mayo Clinic, and basically just talked about the value of partnership. And that's really what we believe in. So I want to thank HFA for allowing us to be here and share some of our resources and a little bit about us. And I will turn the screen over to you. Thank you.
Okay. All right. Well, thank you so much. We are going to be moving into the Q&A portion of the evening. All right, let me just pull up my slide here. There we go. We have several questions. Dr. Kulkarni, I think most of them are for you, but Carrie, if you want to weigh in, of course, we won't say no. The first one is this. First question, the increase in diagnosis, is it because there is an increase of genetic mutations of the X chromosome? Or is it because there is an improvement in recognizing the symptoms?
So I don't know how to turn my video on. It says, oh, the host has stopped.
I think Heather is working on that.
Oh, okay.
Okay.
Here we go.
Anyway.
Hi there. Well, thank you. This is a very interesting question. It's a combination of both, you know. I've been in practice for over 30 years and we never used to have genetic diagnosis, but now we are doing more and more of genetic diagnosis because of availability. Again, insurance is a battle. And I think one of the major things we're trying to do is make people aware of it and make sure that for many women, like for example, genetic diagnosis in von Willebrand's disease is a challenge because it's a huge protein and, you know, you can have multiple mutations and things like that. And we don't know which is the mutation which causes the disease. And in some of the other things, we don't have, you know, genetic diagnosis. So it's a combination of both of them.
Excellent. Thank you. Next question. What is the best way for women and men to advocate for better care for women? Some are standing up and demanding care, which is well-meaning, but may accidentally alienate providers. How do we bring providers along?
So I think once I'll tell you this story because long time ago, or not long time ago, a couple of years ago, I had to give a talk on women and bleeding disorder. And then at a camp, and I found that everybody who attended the camp was a man. So I changed my talk to what men should know about women with bleeding disorders.
Yes.
And amazingly, they were surprised. They really didn't know. And I think the more we talk about women in bleeding disorder to men with bleeding disorder, saying, hey, this could be your sister, your daughter, your mother, or whatever. One of the biggest advocates for women in bleeding disorders in Japan is a physician who has hemophilia, and his daughter also has hemophilia. So they're partners with us, because I am sure they also would like the best of health for women and girls.
Excellent. I, for one, am very thankful for my blood brothers. Okay, next question. Can you recommend ways to document evidence of bleeding and types of evidence of bleeding to share with providers?
Evidence of bleeding, sometimes that's a very tricky question, because some women just complain of bruises, increased bruises. But if they have, the ISTH bleeding assessment tool that we do, that is one way to document, whether the person has bled more than usual. So we all use it in our clinics to some way, what is your bleeding score? So, and Paula James from Canada has also done a self-back that people can do at home by themselves, and they can say, oh, am I bleeding more than, because, for a woman or a girl who has bled all their life, a little extra bleeding, they may think is perfectly normal, and it may not be normal. And then when you put it all together, you say, aha, I am a bleeder, for God's sake.
Absolutely. Next question. Is it true that some mutations tend to bleed more than other mutations? And do you recommend women researching their specific mutation to learn about bleeding tendencies? Also, how do they do this?
Well, yes, there are some mutations which are, mutations that cause bleeding. And I usually, when I face this, I ask the genetic counselor or the geneticist, and there are centers which specialize in mutations. Like, to give you an example, the Zimmerman Project from Wisconsin has given us a lot of information about, pathogenic mutations, and seeing whether those are really the disease-carrying mutations. So we still have to learn a lot about it, but we're getting there.
Next question, or kind of statement and a question, is from a 73-year-old carrier of factor VIII who was not diagnosed until they were 25. Their levels are between 20 and 30, and they have arthritis in every joint and spine and cervical area. Ouch. Are microbleeds real? That's the question. They say they are the only female factor VIII at their HTC, and they suffer immensely. So are microbleeds real?
I think they're real, although there's no way to really test it. But I think a level of 20 to 30%. So I think one of the things I should tell you is a lot of women bleed at higher factor levels. Like I take care of a person who is in her 60s, whose level is like 40-some%, I think 38%. But she has documented bleeds. So yes, you can bleed. And what this patient tells me is every time she gets factor, she feels better. But you have to remember, just like in men, you can get chronic arthropathy and, chronic arthritis, joint replacement. And this woman had her joint replacement during COVID time. So I ended up seeing her by, telemedicine, and she definitely has hemophilia. So what you have is hemophilia. You're not a carrier.
Say it louder. I appreciate it.
You are what I call, there was a term I always used to use. I call women with, hemophilia as shemophilia instead of a hemophilia. So say to yourself and have a t-shirt saying, I'm a shemophilia.
Our next question is, how do I sign up for trials? I'm not afraid of needles and ready to help. My sister would probably join me. I love the enthusiasm.
Yes. So we have some trials. It's not, you have to meet the inclusion criteria. So, and I might say hats off to Dr. Maggie Ragney from Pittsburgh, University of Pittsburgh. She has conducted a trial, and we have participated in it on von Willebrand's disease in women with heavy menstrual bleeding. And, we had a hard time because what happens is many of the women and girls, when they start having heavy periods or having problems, they go to the doctor and they immediately get put on, hormonal therapy. I don't call them contraceptives because they're really not for contraception, they're hormones. And sometimes that excludes them from participating. So it's very hard to find a perfect patient, but I'm sure, we have yelled and screamed and raised awareness that I'm hoping, like, for example, even for factor therapy, most of the clotting factor therapies are for severe patients. Now, I think we'll have to rethink that and see, is there something we can do for women who don't have less than 1% factor?
Excellent. Kind of a similar follow-up question. This person says, my sister and I both have VWD, and I believe one of the other sister has it also. Are there any trials we can be a part of, specifically for VWD?
Yes, there are. But again, that's what I'm saying. The restrictions are the inclusion criteria. If you go to clinicaltrials.gov, you can access all the trials in von Willebrand's disease. And I know that Takeda is offering trials, but for severe patients. And then Athens, has a registry for patients who are on prophylaxis. And I think the new von Willebrand disease guidelines that has come out recently has very clearly said that those who are having problems and symptoms and low levels should be offered prophylaxis. So I'm hoping we will do that, but we will just not offer prophylaxis, but we at least should study it. Is it effective? Is it not? What is the level? Where do we go from there?
Absolutely. Thank you. Carrie, I think this one might be for you. It says, are the LAN, are LAN offered only in HTC areas, or do you try to reach areas where there are not HTCs?
Absolutely. Thank you for that question. We initially started the survey with the HTC network just because that was the largest network we knew of that offered these levels of services. And so, no, anyone can join the LAN, the bleeding disorder LAN, as long as they are dedicated to having designated services for women and girls and the combined services. So we are open, and there are members of our LAN that are not part of the HTC network. So
excellent.
Yeah.
The next question I think is also for you, Carrie. How would someone go about getting a large quantity of the copies of the pamphlets for community awareness, for example, to hand out at schools or other community events?
Just contact the foundation or just email me, and we can work with you on getting you copies. Most of the handouts that we have are available online, and you can download them and print them yourself. But if you need printed copies of brochures and things like that, just contact me and I'm happy to help you. So
awesome.
Yeah.
Give me just a second. I've got to scroll through this chat here. I knew there was a question in here. Okay. We're talking about barriers. How is the foundation helping the LGBTQIA community, specifically the trans bleeding disorders community? Very good question.
Very good question. And that obviously is of big importance to our foundation. And so the first thing that we did now, I want to say it's a year or two ago, we hosted a webinar on the care of transgender people. And so that is on our website, archived in our education section. We also have a plenary planned for our conference coming up in September devoted to this topic. And specifically looking at the risk of thrombosis. And there are some practice recommendations that our Learning Action Network is developing We have given presentations at other society meetings on this topic. The most recent was at the North American Society of Pediatric Adolescent Gynecology. And then we also have a thrombosis subcommittee that is working, that's part of our LAN, both the sickle cell LAN and the bleeding disorder, that is focusing on this topic. We have given educational sessions on gender neutrality as well to our healthcare professionals. And we are also looking at the materials and the clinic names themselves. Some of them, like the pamphlet were go girls or girls only. And now we're changing those names to maybe be the flow clinic or spots, dots, and clots, or just to be more welcoming and making sure that everyone feels welcome when they come.
Thank you. I appreciate that. Dr. Kulkarni, anything you want to add to that?
I think the foundation has done a wonderful job. And actually, I was a part of the National Hemophilia Foundation Diversity, Inclusivity, working group. And, there's an active movement now to be very inclusive of everybody. And I think the foundation, I know, has done the webinars and will be doing more educational thing. I think it's just education. And I think a lot of, in my practice, I haven't seen very many, but I'm getting more aware of it. So I'm open to it and ask questions about hormonal therapy, the risks and things like that. So just to give you an example, we took care of a young lady who wanted to be on hormone therapy, and a young guy, and then was at risk for thrombosis. So those are kind of things that we deal with, that we have to be open about. And, if you get periods, what do you do? And so I think physicians are getting more and more aware. And in some centers, they have clinics for the transgender folks and the LGBTQ community.
Wonderful. Thank you. Another question. Someone is trying to raise awareness in their area. And do we have materials to offer this person? I'll say, of course, HFA has things on their website. And I believe Carrie will tell you they also have things on their website. But are there any other materials you might recommend for someone who's raising awareness about these particular issues for women?
I think our websites are great places to start. There's certainly a repository of brochures and pamphlets and things like that. And also YouTube, we each have a channel that has some wonderful videos that are quick and easy. Our foundation is on there with all of our recordings and symposia and webinars, as well as our Ask the Experts sessions. And I know that you have archived materials there too. And so I think those are some great places to start. And certainly there are other organizations that do specific things as well. So happy to help if we can find what you need. So
thank you. Another question. I know we're getting close to time and we will stop on time. So we'll see how many more of these questions we get done today. Dr. Kulkarni recommended men coming alongside women to help with diagnosis. What are some concrete steps that they can take to support women and girls? What can men do to help us?
So I think it's just not only men, but it should be boys. I think, at least in this country, because of social media and all, everybody is becoming more aware of menses and heavy menstrual bleeding and bleeding after birth. I encourage men and boys to come to the clinic, as a family, and talk about periods openly. It's still a very, woman-based issue. And I think boys should know also, then they don't stigmatize girls or make fun of them if they have bleeding and all this. It's natural. We're all born as women, to have periods and things like that. So there is nothing wrong about it. And I think if it's discussed openly, I think importance of men is also to give a history. A lot of time we ask, especially in von Willebrand's disease, it's amazing to see how many fathers and sons have nosebleed and bruises and this and that. May not be so much the mother, but the father. And having the father or the brother or uncle or whoever is there can help us, not only diagnose them, but also diagnose the little girl or the woman who comes with those issues.
Wonderful. Well, we are at our time. This has been a wonderful evening together. I want to thank Dr. Kulkarni and Carrie Funkhauser again with the Foundation for Women and Girls with Blood Disorders. We appreciate your partnership in this educational opportunity. This webinar is being recorded and will be available on YouTube, I hope soon. Thank you again for your time and preparation with this wonderful material. We thank all of you who have been listening this evening and for joining us. I do want to put into the chat, our next Sister Space event will be June 8th. If you are a blood sister, we'd love to have you.